The views, information, and opinions expressed in Forum 360 are those of the guests and hosts and not those of PBS Western Reserve, its partners, or underwriters.
Welcome to Forum 360. I'm Mark Welfley, your host, and thank you for joining us for our global outlook with a local view. How are you sleeping these days? If you feel a little restless or wake up tired, it may not be the stresses of the world outside, but in fact something inside of you, perhaps a condition called sleep apnea, a sleep disorder when your body is deprived of oxygen it needs due to airways closing, among other things. Nearly 80% of people who have sleep apnea are unaware of it, according to statistics. Today we will talk to an expert who will breathe some new, fresh air into the sleeping disorder of sleep apnea. And my guest is Dr. Ben Utterback, a dental expert and diplomate of the American Board of Dental Sleep Medicine. So welcome, Dr. Utterback.
Thank you very much for having me, Mark.
So you're from Canton, Ohio, and tell me a little bit about how you came to become a sleep disorder expert and expert on sleep apnea.
So I'm originally from Northeast Ohio. I grew up in North Canton, went to Hoover High School. I then went on to my undergrad training at Mount Union and then dental school at Ohio State. I was a general dentist for probably about 17 years, practicing with my father and a few other dentists. And I guess it's a fortunate/unfortunate circumstance on how I got involved with dental sleep medicine. I practiced with a dentist for almost my entire career, Dr. John Barris, great dentist, great friend, and unfortunately his wife passed away in her sleep in 2017, and she was 55 at the time, and afterwards John and I talked, and he was pretty certain she possibly had obstructive sleep apnea. He and I then became more involved, wondering what we could do with our own patients to screen them, to maybe be a person who could look at a patient and say, hey, you should talk to your physician about getting tested. And so he and I started doing some smaller courses on the weekends just to kind of gain more knowledge about how dentists can involve themselves and be part of that screening process for patients. Well, then I looked at John one day. I said, John, I think I'm going to go the whole distance on this. I think I want to go back, do a 2-year training through the American Academy of Dental Sleep Medicine, and then take the board exam after the 2 years to be a true diplomate with the American Board of Dental Sleep Medicine. So I completed that in 2018 and 19, the years I did that. And then from that point on, I started becoming a lot more involved in treating patients, building relationships with doctors in Northeast Ohio. And then at the end of 2024, I sold my dental practice and formed a new practice only treating patients with sleep issues such as obstructive sleep apnea and snoring issues.
So sleep apnea, tell us, what is it and how do you know if you have it?
Okay, so there are essentially two different forms of sleep apnea. We have the most common one, obstructive sleep apnea, which is most commonly where the tongue relaxes at night while you sleep and it obstructs the airway, which causes a total stoppage or partial obstruction of air getting down to your lungs while you sleep. That's the most common form. The second form that a lot of times patients could be diagnosed with, although it's a much smaller percentage, is central sleep apnea. That is when your brain essentially forgets to send signals to the muscles near the lungs to promote the breathing, how people breathe at night then. So we don't see that one as much. With what I do, I only treat patients that have obstructive sleep apnea.
Okay. The apnea, the central apnea, does that develop over time?
It can.
Where the brain just stops delivering the impulses, as you say?
Usually you're going to see that in older adults. A lot of times it's going to be patients that have had a history of having a cardiovascular event. Sometimes patients that have had opioid dependency. Those are going to be patients that are going to be more prone to developing central sleep apnea. Occasionally, patients that have been on CPAP can also be induced to have central sleep apnea because essentially their brain, I hate to use the word, gets lazy, but with the CPAP controlling the airway, sometimes the brain just kind of forgets to send the signals to breathe. So it can be treatment emergent sleep apnea is what central sleep apnea is what they call that.
So sleep apnea, according to the stats and the reports I read, is on the rise. Do you see that, and why do you think that is?
So the main reason, and when I talk to groups, physicians, dental groups, so when I do lecturing, we know that there is a big proponent of what is the word I'm looking for? There's one sector of society that develops sleep apnea is due to weight. So we know obesity is on the rise in our country. I show slides that'll show how our country has progressed with obesity over just even 25 years. I think currently only one state, Colorado, I believe, is the only state that is still considered a normal weight state compared to the rest of the other 49 states. So as obesity rises, we know that we build up fat in our necks, which shrinks down that airway. So we know that obesity and sleep apnea are directly correlated, and that's a lot of the reason why we now know that about 1 in 5 adults has obstructive sleep apnea. Most of them are underdiagnosed, though, or not diagnosed.
Yeah, so is it possible that people have sleep apnea and now there's a greater awareness of it, so the number of cases are on the rise, not because the number of cases is higher, it's just there's a greater awareness and people are discovering it, and so there's more people that need to be treated?
That is correct.
Yeah.
And I think I think people now realize that it's a simple test to diagnose you. You can't just say, well, my spouse snores, or they gasp at night, or they're tired during the day. Does that automatically mean you have sleep apnea? No. You need to have a formal test that is read by a dental sleep medicine specialist. And I think with the improvement of home sleep tests, in addition to the in-lab tests, which we still know are the gold standard of all testing, the awareness and the availability of this testing process has made it easier, and it allows more people to get tested and diagnosed.
Okay, so if you think you have sleep apnea and you seek out a medical professional, their first course of action will be to schedule either an in-sleep study, or they send you some type of device that you hook up on your face or your nose, and then send that back for reading?
That's exactly right.
Okay.
Yeah, so your primary care, and that's how I just worked with the State Dental Board last year on revising how the State Dental Board views dentists and our involvement with this. And our position with the State Dental Board now is we want the patients to get the diagnosis from their physician before they come to somebody like me to be treated. So yes, you go to the physician orders the test, whether they want it to be in lab or at home. That has to be read by a specialist in sleep medicine, and then they get the diagnosis back, and then the physician then decides what type of treatment is going to be best for that patient.
So if a person wakes up in the morning with a headache consistently, or is there some other symptom that can trigger the individual to say, hey, I might have sleep apnea, versus, hey, I woke up with a headache because I didn't drink enough water last night? Or how would someone help self-diagnose, at least to get themselves on the rails to some true diagnosis from medical professionals?
So even online, somebody who's just kind of wondering if they or their spouse might have obstructive sleep apnea, there's a simple questionnaire. It's called the Epworth scale, and it asks a few quick questions, and the patient kind of scores how likely they are to have each one of those symptoms, or how likely they are to fall asleep as a passenger in a car or during a car ride. And that there's a scoring table, and that's one way that a lot of times that's used in physicians' offices. For the specialists that I work with, it's always used to get an idea of how tired this patient is. But it's just one of many ways to really kind of dive deep into it to know whether or not that patient may or may not have sleep apnea.
So if I hear, say, either my partner or my brother or someone snoring at night, should I be worried, or should I say that's the first step towards sleep apnea, or can you be a completely good snorer and still get good sleep and have not be obstructed with having problems getting air to your system?
That's a great question, because it can work both ways. Sometimes we see people who snore and they do not have sleep apnea, but oftentimes there's also patients who don't snore much who have sleep apnea. One difference between men and women that we know, women tend not to snore nearly as loud as men. Women sometimes get underdiagnosed because they're more likely to talk about having fatigue, morning headaches, depression, anxiety. Whereas with men with sleep apnea, we know it's more of the loud snoring, the gasping, the choking in their sleep, things like that. So that's also a reason why we have to be careful on making sure that both men and women are being, referred, even though their symptoms might be completely different, though.
Yeah. Interesting. Okay. Treatments. I know you're a specialist in several of the different types of treatment for sleep apnea, but can you tick through some of the treatments that are widely known and available?
Okay. So the most common, and I still consider it the gold standard, is the CPAP or BiPAP. Either way, it's what we is pressurized air, and what that's doing is, the patient wears it either on their full face, almost like a firefighter would, or just in their nose. And what that's doing is it's pushing air throughout the night and keeping that airway open behind the tongue. So it's forcing the space to stay open so that the patient can breathe totally fine throughout the night. That's considered the gold standard. If I have a patient that comes to my office and says, hey, I'm looking into switching over to a dental sleep appliance and there's severe sleep apnea, and I say, how often do you wear your CPAP machine? They say, I wear it every night, and I wear it 8 hours a night. Well, I'm going to tell them, we're going to keep you there, because we know with what I do with a dental appliance, we know it works really well for mild and moderate cases. So a lot of times we have to know the severity. So CPAP obviously is the gold standard, but we know that the compliance on a CPAP machine is not always the greatest. For mild cases, the newest studies say that it's probably under 40% of patients actually are wearing it after 1 year. So they need to be treated with something. So that opens up the avenue to a dental appliance, which is what I do. For a dental appliance, we bring them in, we do a complex exam, and then we do digital scanning of their teeth. We don't use those old goopy molds that you and I might have had as a kid with our braces. And we make digital models. I then work with a lab. I work with one lab tech at that lab, and we design the case to the patient. We don't take the patient and say, let's hope that you fit into this appliance. Everything is very, very specialized. The third option that we see some patients look into is Inspire surgery. What that is hypoglossal nerve stimulation, and it's actually a true surgery where the patient has essentially almost like a battery pacemaker, if you want to call it, in their upper chest, and then it leads to wires that kind of control the tongue. So every time the patient takes a breath, it's those wire impulses, the electronic impulses, are then making the tongue push forward to get it out of the back of the throat. Obviously, Inspire surgery, it's a newer process. It works very well for some patients. The patient needs to be more on the high, moderate to severe side, and they have to meet certain criteria of having a BMI under a certain amount, and also where the actual collapse in the airway is. But those are the three main ways that patients typically go with treatment choices.
If you're just joining us, thank you very much for listening and for watching. We're talking about sleep apnea and sleep disorders, and I'm here with Dr. Ben Utterback, who is a sleep disorder expert, dental expert, and diplomate at the American Board of Dental Sleep Medicine. I want to go back to something you touched on earlier, which is the mouth impressions. When I first started looking at this story and the interview that we have here today, my perception was that what I saw on TV from 10 years ago regarding CPAP machines was still the reality today, which is loud, covering your mouth. Your partner is, nudging you. You're banished and ostracized. But when I started talking and reading and realized that these machines are really quiet, they're small, they're portable, and so I would imagine a lot of technology has gone into them and developed them to be where they are today. So it's not such an onerous device to have with you. Do you share that view?
I do. I'm like I said, I'm still a big proponent of CPAP machines in general. I do see that a lot of patients now, because of traveling, and if they're going out of the country and trying to find distilled water for their CPAP machine, or going on a cruise, that a lot of more people are still looking for even more convenience, and that's where the dental device does come into play, because they're literally taking a small little case, goes in their backpack for traveling, for people that do camping or are prone to having their power go out. Obviously the CPAP does not work as well. I had somebody recently who does these long backpack expeditions through Canada, and he had a portable CPAP machine that actually had a battery built into it, but he told me that it only lasts like 7 or 8 days, and he said he's gone for 2 to 3 weeks at a time. So those are the type of patients where they're really looking for convenience and not depending on electricity as much. Even the Amish population, we've seen an uptick in the number of patients coming to the office and looking to possibly switch over to having a dental device, because it does not rely on electronic involvement at all.
You've mentioned 3 different forms of treatment, and you touched on surgery, but insofar as that special treatment with the stimulation, but is there a surgical option at all? In the throat, shave down the tongue, I don't know, but you get where I'm going
yes.
with this. Is there some option there that can end all these so-called treatments of machines and dental pieces and apparatuses?
There is. And 25 years ago, it was extremely popular. It was called the UPPP, and that stands for uvulo-palatopharyngeal-plasty. Okay, and what that is a major surgery done by an ear, nose, and throat specialist. And essentially, they go into the patient's throat, they trim out any tonsils, they kind of recontour the soft palate. They're kind of broadening by doing tissue removal and kind of shaving down things, like you said. It's a very in-depth surgery. Patients that have had it done, unfortunately, the tissue does grow back. Just in my experience with dealing with patients that have had that done years ago, and then they kind of redevelop the sleep apnea or the symptoms again. It's not used nearly as much in today's world, just because the recovery is very, very tough. It's probably a good 3 or 4 week recovery after the surgery. And we know it's about 50-60% effective for about the first 2 to 3 years. And then as the tissue starts growing back, then they start kind of having all the symptoms back. So in today's world, I don't see that happen very much. Ironically, with children, which, the percentage of children that develop obstructive sleep apnea is only about 2 to 3% of kids, but that is the first line of defense for kids that do have obstructive sleep apnea, is to remove the tonsils and possibly adenoids right away. They know that is very effective for children.
Interesting. Are there new treatments on the horizon for sleep apnea?
So the biggest one that we have seen, and it's very known to all of our population, is the introduction of weight loss drugs such as Zepbound. It was October, I believe, of 2024, Zepbound was actually approved to treat obstructive sleep apnea. And because what we talked about earlier with the idea of the weight component, we know that if patients do lose a significant amount of weight, there's a chance that their sleep apnea coulds the key word, be resolved completely. Do we see that all the time? No, and a lot of times it's because we know that anatomy also plays a role in this. So anatomy meaning narrow jaw, tongue that sits higher in the mouth than it should, maybe a very narrow, soft palate, teeth that are tipped into each other, reducing that tongue space. But the drugs are going to be a big thing to follow. A lot of times we've seen patients who may not have been a candidate for Inspire surgery or the dental appliance because they were so severe when they were originally diagnosed. Then they go on these drugs for 6 months, a year, whatever, and because they lose, we'll say 40 or 50 pounds, now they get a new sleep study, and the sleep study shows that their severity is no longer in the severe range. Now they're down to a mild range, which makes it a lot more predictable for me to treat them or for them to be a candidate possibly for a surgery or something like that, if their BMI is now lower too.
So the drugs are essentially weight loss drugs.
They are weight loss.
That is the treatment.
It can impact the apnea. Mm-hmm.
I've also seen article stories where if you sleep in a certain way, either your head on the side or tilted to the side, that can either reduce the events per night, or on occasion, when I'm on my desk, I kind of lean over and just put my head down where I'm looking down, and that seems to give me better breathing. Is that true, or is this just an old wives' tale?
No, you're exactly right. So every time I treat a patient, I'm always asking the referring physician for their sleep study, and that's one of the first things I'll look at is there a positional component with this patient or not? Just like you said, patients that sleep on their back, for the most part, I'm going to probably say at least 90%, are worse when they're on their back compared to their side, and that's because gravity takes over, and if they're on their back, guess where that tongue's going? It's falling right to the back of their throat. So sometimes I'll talk to patients, especially the patients that are more in the high, moderate, low, severe range that are asking me to treat them. I'll talk to them about getting a positional pillow. They make all kinds of different pillows and adjuncts that you can use to sleep while also using an oral appliance. I also talk to patients about using nasal dilators and occasionally mouth tape as well, because we know nasal breathing is much more efficient than mouth breathing. And a lot of times patients come to me with complaints of dry mouth, things like that, and that tells me that they're breathing too much through their mouth. And if they're able to breathe through their nose, why wouldn't we encourage more nasal breathing? So yes, positional components, adjuncts to aid in nasal breathing, those are all things that we will use in addition to the oral appliance.
Sure. I think that when you fall asleep on your side, you assume that you stay on your side the whole night. But I think the reality is you don't know that, and you actually turn and maybe lay on your back, and then you get an instance or an event, and then you wake up on your side, well, this is good. But really in the night you've been moving and doing all other types of activities that have not been necessarily helpful to counteract sleep apnea.
That is a common eye-opener in my office when I go over the sleep study with the patient at the consult. And I said, well, you were on your back for 3.5 hours of the night. And they're like, no, I went to sleep on my left side. I woke up on my left side. I said, yeah, but these are tracking you as you're sleeping all night on whether you're on your back or on your side or on your stomach. So sometimes a little bit of education on what's happening throughout the night also will help a patient gain better quality sleep too, if we can know these things at the onset.
Well, can you put foam bricks on either side so that you can't turn? Does that work? Or
for some people that works well. A simple wedge pillow that you can get off of an online Amazon, something like that. Even I've had patients who have taken fanny packs, and they take the fanny pack, move it around to their back, put a baseball or a lacrosse ball in there, and that keeps them from going on their back too. So there's lots of ideas that I talk to patients about before we even start treatment, if we know that is a big issue in terms of their own sleep. It's not for everybody. Not every case is the same, but for the people that show they're 10 times worse when they're on their back, those are the patients we really want to try to focus to keep them off their back to make my therapy more predictable for them and more successful.
Sure. In the last 30 seconds we have, could you Could you take us 10 years into the future and tell us where you think sleep disorders and maybe sleep apnea will be?
I'm hoping that it becomes widely more, where patients are more tested, where it almost becomes like, you go and you get your cholesterol tested. I want it to be something where it's on the forefront of all diseases. We know that it's the second leading disease behind hypertension in the United States. So I'm hoping there's more awareness, and it almost becomes, even if you don't have symptoms, that you are tested just to rule it out.
Yeah. So you don't ever see a cure for it. It will always be a treatment.
It's probably always going to be a treatment for it. Yep, I do.
Thanks. This was very interesting. It's hiding, perhaps sleeping, in pure sight. Sleep apnea is a treatable condition that affects nearly 1 billion people worldwide. If we can recognize the symptoms of sleep apnea in ourselves and in others, we may be able to wake up to improved health and a better quality of life. I'd like to thank my guest, Dr. Ben Utterback, sleep disorder expert and dentist from the Dental Sleep Solutions of Ohio, for the visit today, and ask each of you to keep your eyes, ears, and mind open. Until next time on Forum 360.
Forum 360 is brought to you by John S. and James L. Knight Foundation, the Akron Community Foundation, Hudson Community Television, the Rubber City Radio Group, Shaw Jewish Community Center of Akron, Blue Green, Electric Impulse Communications, and Forum 360 supporters.